All right. Hi, everyone. Welcome to our December team training webinar. So excited to see all of you. I see some friendly names in the chat. And today we are excited you are all here for our December webinar, where we're going to be talking about enhancing patient safety, understanding and leveraging a unit safety score for improved outcomes. So feel free, we're going to use our chat today. Feel free to say hello, where you're calling in from, and your role. And also, if you have any fun wintertime traditions, we were just talking about baking, so let us know that as well. Okay. All right, so just a few rules of engagement for today. You can access your audio by listening through your computer speakers or through your phone. You are in a listen-only mode. We are going to do a Q&A session at the end of the presentation, so if you do have any questions throughout, feel free to just put them in the chat, and we will get to them at the end. We are recording this session, so the chat will not be included in the recording. And just so you know, there is a, on the bottom right-hand part of your screen in the chat, you just make sure you are chatting to everyone. You can also chat to the host and panelist if you toggle between, if you are having any audio issues or need support. We are happy to offer free CEs for our webinars. To claim your CE credit, you must create a Duke OneLink account. This is a one-time only setup, and my colleague Rachel will be chatting in those instructions. You can also refer to the email that was sent to you this morning with the attachment. And following the webinar today, please text FUPREX. We'll give you that at the end today as well, to the number that you see there, and we'll share this, like I said, at the end as well, to make sure you get your credits. We are excited to announce we have information on our 2-day TeamSteps Master Trainer courses on our website for 2025. So if you have been curious to attend one of the regional trainings, take a look at that site. Our master training courses teach the TeamSteps 3.0 tools, along with exclusive content related to TeamSteps training design, psychological safety, and stakeholder resilience. So if you are interested in registering for one of the courses, please note we do encourage teams to attend, and we do have a team discount, so you can visit our website to learn more. And then in addition to our in-person courses, we do have registration for our virtual master training course that runs 8 weeks, now open as well. Also, to give you insight on our custom TeamSteps advisory services, if your organization is interested in a custom TeamSteps training on site, we have our TeamSteps advisory services. This is where we work one-on-one to provide a customized master trainer course or a comprehensive TeamSteps programming. So if you're interested, you can learn more and sign up for a one-on-one information session with our team training clinical program lead, who can share more information with you. We would love to come on site and train your teams in 2025. All right, so I'm so excited. We have a very special guest today, Leanne Teague, who is the Senior Director of Performance Improvement at Our Lady of the Lake Health in Baton Rouge, Louisiana. Leanne, thank you so much for joining. I am going to send this back over to you to share more about your organization and the unit safety score.
Perfect, Amy. Good afternoon. Thanks for having me. Thanks to AHA for inviting me to speak. As Amy said, my role today is Senior Director of Performance Improvement, which includes the areas of patient safety, infection prevention, quality data analytics, and the Lean Project Management Office. My background is a medical technologist with a specialty in blood banking. So I'm excited to be here to talk to you about the unit safety scorecard developed and used by Our Lady of the Lake Health. I'd love to hear your thoughts or your questions as we go along, so feel free to drop them in the chat. I have some great facilitators who are helping me manage that. So let's dive in. All right. So by the end of this meeting, I aim to explain to you the components of the unit safety scorecard, to demonstrate the calculation of the weighted unit safety score, and to encourage ongoing engagement with the unit safety score for continuous improvement in your organization. To give you some context of where I work and where the unit safety score is being used, I'll describe to you our hospital system and where it's located. So we are a Catholic healthcare system comprised of 6 hospitals in the states of Louisiana and Mississippi. As part of the Franciscan Missionaries of Our Lady Health System, we have a flagship hospital with 1,000 beds in Baton Rouge, Louisiana, which is where I reside. And in the Baton Rouge market, we have 2 adult acute care hospitals. We have a children's hospital. We have a critical access hospital, a rural emergency health hospital, and 2 standalone emergency departments. Our Lady of the Lake Health is comprised of an extensive array of facilities and offerings to the public of Baton Rouge. Our units are a combination of medical, surgical, critical care, neurological, and trauma. The attending physicians in these units range from academic internal medicine residency program to a teaching private hospital system to a trauma team and consulting surgicalist. The safety culture at our organization has been cultivated since 2015 through the creation of a lean project management office, daily tiered huddles, and weekly safety rounds. In 2021, we began, which seems like such a long time ago, we began working on the unit safety score. And we had a couple of goals in mind. A goal with this scorecard was to support our collective mission of providing the best care possible. To achieve that, we knew that we needed a system that ensures consistency across the units, gives us a clear and honest view of hospital-acquired harm, and it remains fair and objective to everyone involved. Additionally, one of the key goals with the scorecard was to give practical insights to help strengthen our culture of safety. By turning data into actions, we can continuously improve patient outcomes and create a safer environment for everyone. That's our team members and our patients. So consistent, meaning measured equally, transparent, meaning all are aware, objective, meaning we're focused on data and outcomes and not focused on, personal performance or personal behaviors. So what was our why? Why was this important to us? So creating a unit safety score instead of distributing individual packets of data by unit really offers several motivating factors to us, particularly from the perspective of efficiency, clarity, and impact. So at prior state, we were sending 9 packets of information, basically 1 packet per hospital acquired condition to our nursing leaders. When they received those packets, they were expected to find the pages that correlated to their unit, pull it from the packet, and then post it on they have quality boards in each of the nursing units. So not a hard task, right? But time consuming. What was hard about it was understanding the types of graphs that we were sending to these team members. They were dual axis graphs. They had 2 bars, observed and expected, and they had this run line that showed a SIR or a rate. There was just, for people who aren't data analysts, it was a lot to interpret in the really short amount of time that you have available in front of a quality board, right? And so then we put together a multidisciplinary team consisting of quality physicians, infection prevention experts, and data analysts to work collaboratively to design and implement the scorecard. The development of the scorecard spanned a lengthy and disjointed timeline, with progress initially interrupted by the global COVID-19 pandemic. However, the process was ultimately enriched by the contributions of a talented group of LSU students. LSU is our flagship university in Louisiana. whose fresh perspectives and really very innovative ideas elevated the final product. So ultimately, we went live with the Unit Safety Scorecard in August of 2022. Now I want to draw your attention to what you're about to see. These are the two most critical slides in the presentation. This is the first one of it. These slides really encapsulate the core insights and the outcomes of our work, providing you a clear picture of the scorecard components. The first slide highlights the unit performance, showing the progress made in areas that need focus. You can clearly see the color indicators. The second slide I'm going to show presents the trends and the individual domain score makeups. And so together, these two slides are the foundation for our discussion today. So let's dive in. So we've previously established that the unit safety score summarizes safety performance measures in an effort to help the inpatient units identify preventable patient safety issues, right? So I'm going to call your attention to the top middle of the screen. The unit safety score is calculated on a rolling 3-month basis. You see here July, August, and September. Secondly, on the middle left side of the screen, you see each of the 11 domains. They are weighted as a fixed percentage of the final score, and it includes 8 harm events and 3 events that encourage best practice. The harm domains are hospital-acquired events, or harm, caused by hospital processes. And then the best practice domains are processes that serve to mitigate harm events. And then I also want to call your attention to the far right column, because everything we do should be centered around the patient. So as not to lose focus on the patient, the third column represents the number of individual patients harmed or benefited by the processes. And then ultimately, at the top center left of your screen, you see the overall rating, which is that great big blue box that says effective with a score of 3.960. So this is the opening page that any unit will see when they receive their unit safety scorecard. This is the page that our nursing leaders are posting onto their quality boards today. So as you can see, quick drive-by, team members can see where they're doing really well and where they need some individualized focus. So this is page 2 of these 2 critical slides. The supporting pages behind the cover page include details for each domain. So it gives you a little bit of description of what we're measuring. Here's the index and the weighting behind one of the unit safety scorecard non-harm domains. This is hand hygiene for this unit. So for each of the 10 domains, we set an indices for each measure based on internal or external benchmarking. And then we set a weighting. So your indices for your organization is going to look different than the indices for Our Lady of the Lake Health, because you're going to have different internal benchmarks and you may choose different external benchmarks. So we target a 3, but we strive for a 5, if that makes sense, right? We want to be at least a 3, but in an ideal world, we're a 5. So the domain specific score is generated from the unit's performance against the indices. So for example, we participate in the Leapfrog survey. And as part of that, we capture hand hygiene performance. So you see the unit indices on the right-hand side of the screen, that's the 1 through 5, and how many hand hygiene audits that we expect to be performed for each of those 1 through 5s. So at a performance of 988 events over 3 months, this unit has a 3-month score of a 5. So just take a minute to process that. So then when you see the weight at 4% here, weights were set in conjunction with our infection prevention risk assessment, where we look at the probability of harm to occur, the risk impact to the patient, our preparedness level to mitigate or respond to those risks. And so, for example, if C. diff is a larger problem in your organization than, say, CAUTI, then your C. diff is probably going to have a higher weighting than CAUTI, and so on and so forth through the domains. And you may choose different domains than we have chosen. So let's pull all that together. So the domain weight multiplied by the unit monthly score, or the unit score, equals the weighted score per that domain, for that domain. Okay, so in this case, 4% times a score of 5 is the weighted score for hand hygiene. So then when you sum the weighted scores for all those domains together is how you get the overall unit score. So which is how this unit has the score of 3.96, which is what you see on the right-hand side. So this consistent approach is applied to each inpatient nursing unit. We have set indices at the unit level, at the hospital level, and at the market level, ensuring that the unit safety score is applicable and meaningful to stakeholders across all levels of the organization. So again, 2 slides, most important to the conversation about unit safety score. And I want to pivot at this point to, now that we've covered kind of the background and the key concepts, I want to kind of bring this to life for you in a real world example of how we operationalized it, and it continues to grow. And this case study will illustrate how these principles were applied, demonstrating their impact and providing actionable insights for similar scenarios. So, how many of you watched any part of the Summer Olympics? And I can't see you on screen, but I'm guessing that you're raising your hand or you're shaking your head, right? And because I think everybody watched some little snippet. Do you think that those athletes strive to be average? Did Noah Lyles, the fastest man in the world, get up every day, work out to be labeled as average? Would you label Katie Ledecky, the women's most decorated swimmer, as moderately effective? And then let's get a little bit personal with it. If you see moderate or average on your own personal performance evaluation, are you satisfied with that? My guess is no, because you are attending the seminar. You are someone who wants to excel and wants their organization to excel. And so for you, moderate isn't just a word, it's a challenge to really push beyond to achieve excellence in every endeavor. And so what you see on the slide in front of you is the unit safety score excerpt from the rolling 3 months of February through April of 2023. This is an overall representative of the Baton Rouge market inpatient units, which is made up of, again, the 3 acute care hospitals. At this time, the unit safety score for the Baton Rouge market was 2.930, which was a moderate performance across our quality metrics. And more importantly, it was a clear signal to us that our patients were not receiving the quality of care that our mission drives us to deliver or that our team members seek to provide. So in response to this signal of moderate organizational effectiveness resulting from increased hospital-acquired conditions, we initiated a systematic approach to reinforce standard work practices throughout the organization with a goal to reduce patient harm. So this approach required a performance improvement foundation. It required buy-in from leadership, and ultimately it really required the team's commitment to patient safety. So utilizing our organization's existing commitment to what we call 100-day workout methodology, we developed a focused drive whereby all the leaders would spend the summer months ensuring that their team's practice at the front lines displayed organizationally accepted standard work practices to support the evidence-based practice related to prevention of hospital-acquired conditions to reduce harm. We called it the Patient-Centered PI Summer of Excellence, and this is the statement that you see on your screen. It was created to succinctly share our objective. So the timeline from decision to launch was rapid, but even more rapid was the duration of the 63-day sprint. And I'm going to go through each of these details in subsequent slides so that you can visualize the timeline. So working closely with our C-level executive and nursing leadership, our performance improvement team spearheaded really an all hands on deck effort to address identified areas for improvement, assuring alignment with our organizational goals and fostering that culture of continuous improvement. And so each unit was assigned 2 improvement topics. The individual unit performance was assessed using a heat map of the unit safety score, which is what you see on your screen. So this is not a heat map is not something we typically produce for our units to look at. But for setting up this PI Summer of Excellence, we pulled the heat map of the unit safety scores, and then the selections of the topics were tailored to each unit's lowest performing harm domains. So as one of, in addition, as one of the 2 topics in our non-critical care units, we assigned them the Johns Hopkins Activity and Mobility Promotion Initiative, which was a project that we were kind of in that improvement phase of. And the idea here was to enhance patient mobilization, patient movement to reduce the hospital-acquired conditions of harm and pressure injuries. So we recognize that to accelerate performance in such a short window of time, leaders would need resources to support their efforts. So we worked with nursing leadership. We worked with infection preventionist experts to develop the succinct standard work guide or a handbook. Now, mind you, all of these practices were well documented in other policies and SOPs that we have, but we wanted a much more succinct work guide. So we created that. And then these practices were tried and true, not only in literature, but also within our institution. So they're accessible and measurable and able to be executed quickly by our unit leaders. So essentially, we weren't asking them to do new things. We were asking them for a return to standard work. We leveraged existing systems and structures, and we refreshed our leaders on a previous performance improvement competency that we had taught across the organization. We call it a problem-solving storyboard, is what you see on the screen. You probably know it as an A3, same thing, just a little bit tailored to us. And what this does is it allows the leader to customize their root cause and implementation of solutions to their unit needs, right? Because the root cause on one unit may not be the root cause on the next unit. So they got to tailor their solutions, again, based on the evidence-based practice. We also used an existing, what we call PI Studio Forum, which is held every 3rd Wednesday, and we transformed the June 23 PI Studio to launch this summer sprint. And within that meeting, we shared the vision. The vision was created. We did some refresher education provided for the unit leaders. And this was what we consider the start or the kickoff of our 63-day sprint. So 3 times throughout the sprint, the hospital leaders, accompanied by performance improvement leaders and infection prevention teams, rounded on each unit to discuss the storyboard's progress in an open dialogue with unit leadership and team members. To supplement these 3 rounding sessions, one-on-one coaching was available on demand to leaders every week on Tuesdays from 1 to 3 p.m. And at the conclusion of the sprint in August, in the department head, many of the outcome measures related to hospital-acquired conditions and the unit safety score were unavailable due to their lagging nature. So you guys know this. Naturally, in many of those domains, some of that information lags behind to more the middle toward the end of the month sometimes. So we couldn't share all of the results in that August department head when we kind of concluded that 63-day sprint. But what we could share immediately was the impact to the Johns Hopkins mobility project. So remember, if you will, this initiative was assigned to the non-ICU inpatient units as one of their 2 storyboards. And over the course of the summer sprint, we accelerated the scaling and adoption of this project from a pilot 4 units to all of our 15 nursing units. And the documentation practices were an immediate signal that our patients were experiencing a mobility culture shift within the walls of our hospitals. We knew that a mobility culture does so much more for patients than getting them walking. It's also directly linked to their likelihood to develop hospital-acquired pressure injuries or to fall while they are here. Ideally, it also helps them to go home and not to an intermediary facility. So both of which were problematic areas within the unit safety score, if you remember what that heat map looked like. And so also want to show you at the top of your screen, some of you are saying, oh my gosh, Leanne, you guys have the longest length of stay I've ever seen in an acute care hospital at 8 days or 7.3 days. Well, not really. The criteria to get into this data set was that the patient must have a length of stay greater than 3 days. So really the takeaway from this slide is that as our culture of mobility improved and as our documentation improved and as our patients are getting up more often, we see the length of stay decrease. So shout that out to all of the people yelling at you for throughput issues, and you go back, therapists that are in the group, and tell them we just need to move our patients. There is some evidence behind mobility and shortening the length of stay. So what length of stay was not something that we were initially tracking during this project because, length of stay is such a lofty goal and there's so much that goes into a length of stay. But we found it curious after we did this PI summer sprint, if we could overlay it, what it would look like. And those were our findings. So just to reiterate, the timeline from problem recognition to conclusion was a really short 63 days. But as you'll see in the next few slides, it was impactful. And while we weren't able to immediately see all of the benefits, we were able to clearly see them. And so as time went on, we realized the true impact of how Our Lady of the Lake Health reacts to challenges such as the summer sprint, right? A little bit like the Summer Olympics. And so what we saw was that 94% of the units focusing on implementing the Johns Hopkins Activity and Mobility Promotion Initiative demonstrated improvements in mobility documentation. The overall hospital score for mobility increased noticeably from 39% to 54%. And then additionally, 74.2% of our inpatient units saw improvements within their focus domains in the unit safety score, indicating that targeted interventions were effective. So these quantitative improvements were complemented by qualitative feedback with staff reporting and increased awareness and adherence to safety protocols. Patients also experienced enhanced care and reduced harm and improved mobility practices. So another visual here of the unit safety score that we don't typically pull and we don't typically show, but furthermore, the outcomes of our interventions were significant, leading to tangible improvements in patient safety measures and organizational effectiveness. Then the market unit safety score rose from a moderate effective range, which remember is what initially caught our attention, to the effective range. This improvement was sustained for at minimum the 6 months post-intervention, which we believe reflects a substantial enhancement in safety performance across inpatient units. The project showcases the potential for large-scale changes to safety outcomes in a shortened timeline via utilization of data-driven decision-making combined with collaborative and effective team-led strategies for addressing patient safety. So overall, our project's impact extends beyond the numerical metrics. It fosters a culture of safety and it fosters continuous improvement. And so by addressing the key safety challenges and implementing evidence-based interventions, we've positively influenced patient outcomes, employee engagement, and organizational performance. This success really underscores the value of our approach in driving meaningful change within our healthcare setting. So again, this method fosters, the regular cadence-based opportunities for teams to address complex challenges that may be difficult to integrate into daily tasks. The utilization of the unit safety score really enhances the visibility and underscores the value of patient-centered decision-making. And this forward-thinking approach allows for nimble adjustments and quick responses to emerging needs, ultimately driving meaningful improvements in patient safety and care delivery. So it's important to know that the unit safety score was a brand new tool to our organization in August of 2022, right? And this project, saw on the timeline, didn't kick off until April 2023, which was a full 8 months into using the unit safety score. What we recognized was that there were gaps of leaders understanding the unit safety score. And so this rapid cycle improvement really helped us to close any of those gaps in understanding. We got to go have some conversations with them about how to read it and how to operationalize and how they can do improvement local to their unit. Doesn't take a PI summer sprint of excellence just by looking at their scorecard. And that resulted in feedback from the leaders that having the data organized in a way for them to easily interpret and make critical decisions was impactful to them. So really just make sure your data strategy supports the end user being able to make those critical decisions easily. We're all in this work together. We're all supporting each other. Some of us are on the front line, some of us are not. But we work collaboratively for the success of the patient. So one of the things that we did following kind of the summer sprint, and really we've done it twice, following the kickoff of the unit safety score, but also the sprint, is that we did kind of some VOC, voice of the customer data collection. And what we hear is that we love that we only have one page on our quality board that we can see our overall performance and quickly see where we're performing well and where we have opportunity. It is easy for us to read. We understand colors. It's easy for us to read. It's easy for us to understand. It's so much better than these run charts and observed over expected and standard infection ratios and all this kind of stuff. So, and it really, and then it pulls everything from the hospital together. So from the inpatient to the hospital to the market level. And so really, I think I sped through that probably faster than I thought I would, Amy, but I'm hoping I was not watching the chat because you guys can do that for me. So what questions do we have out there?
Yeah, well, great job, Leanne. Thank you so much for sharing. You've gotten many kudos in the chat around this work, just great work. And also just thank you for your leadership and really sharing some of the sensitive information and kind of paving the way for others. We do have many questions, as I assumed, and let me get to some of them. So we did have a question in the beginning. How do you share the scorecard? Like, what does the frontline access look like?
Yes. So we have what we call a dashboard marketplace posted on our intranet. So we have access a couple of different ways. So leaders can go into the internet and they can pull their unit safety score down from there. I do know that in our largest regional medical center, we have our administrative assistants who will print so when we post it to our dashboard marketplace, it also goes out in an email format via smart flows, Microsoft flows. So everybody knows that it's been posted there, that the latest one is there. Our administrative assistants are part of those flows. And they will print it out for our nursing leaders who have the least amount of time to go to a computer and print something. And they put it in their mailboxes, and then those nursing leaders just take that one page and they post it up on their quality board. And then they do they'll have weekly meetings around their quality boards. And then when we do patient safety rounds, we huddle around those quality boards and we will ask them, how are you doing in your unit performance? What are the areas you're working on? So it's a way for us to double check that they do have that latest one. It is posted up there and they understand how to read it. So it's kind of this continuous cycle of making sure that it's in use.
Awesome. And talking about frontline staff, and you talked about this a bit with the education that you worked on with your staff to understand the index score. So you talked about that summer of excellence with resources, and then you talked about going back and having some candid conversations. Anything else you want to comment on around how you educate the staff to understand the index score better?
Yeah, I will say the index score was not at all the problem. The index score was understanding a weighted scorecard, because what they wanted to do was kind of average the scores and make that their overall unit safety score. But we recognize that we have the things that, as I said earlier, the things that we have more opportunity in, maybe that's bloodstream infections or whatnot, need to have a little bit higher weighting, because we need to really push the teams to improve in that area. So the challenge, the indices, I think they were good with. The challenge was in that overall effective score. So not only did we do rounding and have those kind of one-on-one hard conversations with them, but we host multidisciplinary quality meetings with rotating topics every single Wednesday afternoon. In fact, there's one happening right now. And the unit safety score is one of those rotating topics in that multidisciplinary quality meeting. And so every quarter when we're talking about this, leaders have the opportunity to ask questions about the unit safety score if something comes up. And then again, like I said, in patient safety rounds, we talk about it. So really, team members have a lot of opportunity to interact. Even our frontline team members have a lot of opportunity to interact with us, the developers, if they have any questions.
Perfect. All right, and I apologize. I got kicked out and I'm back. Can you hear me?
I
All
saw
good?
that.
Okay.
Yep.
I was like, oh no. Okay, perfect. And oh, we have so many questions. This is great. Okay, and I knew we would, because I remember you sharing this in the past, and it was a very popular topic. So how did you go about setting the unit indices for each unit, for each domain?
Yeah, so the example in the slide deck was hand hygiene. So Leapfrog really tells us what that indices is. They say that inpatient unit should have 100 hand hygiene audits every single month. And so we took that 100 and we said, okay, since this is a rolling 3 months, then our target is a 3, then our target is going to be 300. Okay, there's a range, right? So in some of our indices, we said it's plus or minus 10%. In some of our indices, we said it's plus or minus 20%. Like, we really had to look at what's achievable, right? And then what is this? It's no different than setting performance goals for your leaders. Where are they? What's their baseline? How are we performing? Okay, and then if we do just a little bit better or a little bit worse, what does that range look like? So for some, it was Leapfrog. On our safety event reporting, it was looking at how many safety events across our inpatient units are typically reported in a fiscal year. And then let's average that, and that's our 3, plus or minus our 10 or 20%. And then we set our 4 and our 5s and our 1s and our 2s from there. For some of our hospital-acquired harm, CLABSI, CAUTI, it's what are the NHSN percentiles, right? And where are we performing in those percentiles, and what percentile do we want to be at? Look at the top reports, right? And so it's a process, right? You saw that we started looking at this in 2019, interrupted in 2020. This was not an overnight development. But that's how we went about setting our, again, a mixture of external and internal indices, benchmarks to set the indices.
Yeah, I appreciate that. And we do have a few data questions as we're on that topic. Was there, I guess, what platform or program was used to collate and display the data? And then how much is manual versus automated?
Yeah, the good news is you don't have to go out and buy any third-party system to do this. We use Tableau as the visual. Some of our data, most of our data lives in an Excel format that's then linked to Tableau. So for all of those individuals on the line who know Tableau well, they'll understand. Most of your organizations today probably already purchase Tableau for their finance teams, decision support, business analysts. So it's a tool that's available to you. So you don't, what was the second part of your question? It was,
Yeah, so Tableau for like collating and displaying the data, and then how much of the data input is manual versus automated?
um, so the manual is really just pulling the data out of our electronic systems.
Okay.
So there's safety event reporting. We use RedCap as a survey tool, as a database for hand hygiene audit. So, we're linking Excel from RedCap into Tableau. And some of this is, we're downloading data from NHSN into an Excel document that's then linked to Tableau. So, back in the day, in prior state, before the scorecard, Excel, if you're still working in Excel, it's a very, very tedious software. I think it's tedious on the visuals. It's tedious on creating the visuals. Tableau has made that much easier. So, um, I'm not going to lie to you. The unit safety score is dedicated probably 2 to 3 hours in the month to produce, you know. But considering a 40-hour work week, I don't know that 2 to 3 hours is that exorbitant of time.
Perfect, thank you. Okay, let's see. Any plans for incorporating, I know you talked about that lagging data being a challenge for improvement. Any plans for incorporating real-time data within that unit safety score or any feedback?
Yeah, so advances we've made in the unit safety score since the initial go live with the inpatient units are we have added the emergency department unit safety scorecard. We are within a month of launching a specific children's hospital scorecard. And within a couple of months of launching a surgical services division scorecard. I think, we use Epic as our EMR and it refreshes constantly. And we rely on a lot of the dashboards in Epic to give us that real-time feedback of how we're performing from, door to discharge time or number of boarders or, how many patients have lines in that are expired that need to be changed. I don't know. I'd be interested if somebody has feedback on how real, because at current state, we produce this monthly, which doesn't really facilitate that real-time data being published. But I don't know, maybe I will get my vision brain on and think about how we can make the unit safety scorecard maybe more dynamic.
Yeah. Well, if any of our 163 participants have anything they'd like to share from if you are using real-time data or incorporating that into anything like this, or have any ideas, feel free to share in the chat.
Yeah, we'll get you on a seminar. Yeah.
Yeah. Awesome. Okay, so talking about implementation of this and like the improvement process and knowing that this is a group that really focuses on teams. You talked about really this being a multidisciplinary team effort, as well as the development of this and like in the rounding, all of that. I'm curious, did you find a way to draw out any of the non-unit based staff into the improvement process, like EVS, facilities, or others?
Well, yeah, we are active participants with EVS, because we in Louisiana, and this doesn't exist in all parts of the country, have a hospital-acquired C. diff problem. We have a community C. diff problem, and so therefore we have a hospital-acquired C. diff problem. And so EVS has been instrumental, clearly, in the discharge clean and the cleaning process to prevent C. diff. So yes, we will call them in for assistance when we see unit scorecards with C. diff, and we'll talk through their processes for cleaning, as well as the team's processes for their PPE and whatnot. Infection preventionists have been a big part of this. When you talk about, so mobility is on our scorecard, and a lot of the team members who are helping our patients move are the CNAs, right? They're not the RNs that are caring for the patients. And so that ancillary staff who lives on that unit are actively engaged in the unit safety score. Because they've got hands-on patient care as well. I think an area of opportunity that we have is for a unit safety score is in our lab and imaging and pharmacy and those real ancillary departments who provide patient care but not direct patient care, right? And that's so in our development, moving to the ED and surgical services, and on our radar is our mental and behavioral health. But I think in the back of my mind, there's also those ancillary units and departments, and how do we incorporate their performance?
Yeah. Perfect. Thank you. And to the question earlier that we asked of the group around more of the real-time data, Leanne mentioned that they use counted data, falls, infections, etc., between monthly rate updates for the front line.
Yeah, just raw counts. But yes, that is important. So we talk about that daily in our daily tiered huddles. That's part of our culture of safety. We talk about, was there any team member harm? Was there any patient harm? What are our operational issues? And so most every day, some units reporting a fall of a patient. Every week or so, somebody's talking about pressure injuries. And so while we don't produce that, we do have a daily tiered huddle report that is visual that we show during our daily tiered huddles, where we can see a count of falls or pressure injuries or bloodstream infections. It's not a report card that we're putting out. We're kind of just verbally talking about it as a team.
Perfect.
But I love that. That creates the culture, right? When you talk about it, it creates the transparency that creates the culture that helps people be comfortable in talking about all things patient safety.
Yeah. Thank you. And a new question, and I think you just touched on this a little bit. So the unit scorecard appears to give that high level overview of unit performance. Are units able to drill down to more specific areas for performance improvement related to outcome measures?
So in the background, we still produce every single one of those dual axes run charts by unit that will show them the trend over 24 months that they can further drill into. So the supporting page will just show you a little snapshot and account, but we still produce all of the data that they need to drill down even further into. We get a lot of calls about the safety event reporting. I don't know if you noticed, we have two domains in safety event reporting. One is the harm domain, and we use RLDatix, which categorizes events as an A through an X. And so one of our domains in the unit safety score are the G, H's, and I's, which are the significant patient harm. And you don't expect to see a lot of those, right? And then our other domain is a best practice domain that includes all level A through X events, because we want people to report. We want to hear about safety issues. We want, our pharmacists to report. We want our intensivists to report. We want our hospitalists to report. We want our academic learners to, we want everybody to tell us because if we don't know that it's happening, we don't know that there's a trend or something that we need to be digging further into to find root causes and improvements for. And so where was I going with that? I totally lost my train of thought. What was the question?
No, I think so basically, the units still have access to this detailed
that's one of the questions we get to that. When they see a GH or I on that domain, thank you, Amy, they'll say, hey, I don't remember this event. What was that event? It's okay. We got you, you know, and they know we have that, we have a really good, you know, I can't brag on our nursing leadership enough. They are a phenomenal team, and we have a good in quality analytics and performance improvement, have a really good relationship. So, you know, there are phone calls, there are always conversations. If they ever need anything to dig into that performance, it's an easy reach out. It's a comfortable reach out.
Yeah. Very cool. Okay, we got more and more questions coming and 10 minutes left. So
I
thank
love
you
it.
all. This is great. I had a feeling that this would be a popular topic. Okay, so can you share what your critical care area is focused on?
Our critical care unit safety scorecard looks identical to
Okay.
the medical surgical. So that's the beauty of it. It's very consistent. What I really didn't talk about was our patient-centered service line. So we have in this unit safety score organized groupings of units based on patient flow, not based on level of care. So in much of our data we produce, how are the ICUs doing? How are the med surg units doing? How are the mental and behavioral health doing? Whatnot. In our unit safety score, we organized it by patient flow, which means units can be in multiple patients in our service line. So example, a patient who goes to our surgical intensive care unit may step down to a surgical medicine unit, right? And so that SICU and that surgical unit are aligned in the patient-centered service line of the unit safety score. So what this does for us is hold units accountable to each other. If I am receiving a patient from SICU, then I want to see SICU's performance. And if they are doing well, the quality of the condition of the patient that I'm going to get, right? Have their lines been looked at? Is their Foley removed if they don't need it? That sort of thing. So it creates the conversations between the nursing leaders on how well they're performing up and down that patient-centered service line.
Oh, that's really interesting. I
Yeah.
love that. Okay. A comment that this is very impressive work, and if there was something you would have wanted to do differently in your implementation, what would that have been?
Oh, I wish I wouldn't have had those gaps for 8 months, that I didn't
Hmm.
realize that the leaders weren't quite understanding
Okay.
what was happening. I mean, better that we caught it 8 months in rather than 3 years in. And right, so I wish, yeah, I probably would have done that VOC and more one-on-ones closer to the go live timeframe than when we did the rapid cycle improvement and we identified it. I will say that, you know, when you guys are working on this, a tip I have, we would not have been where we are without those really bright students from LSU. You know, they came in with such a fresh perspective, knowing nothing about healthcare. They don't learn healthcare in master's programs of quality analytics or masters of analytics, masters of science analytics. They don't know anything about healthcare, but they came in, and so I would encourage you to get that fresh perspective, even if it's not from your local university, but go out and look at, because if they can understand the data, I can guarantee you your nurses can understand the data. Right. But that's just tip.
That's a
Yeah.
That's a great tip, especially for others who might be interested in starting something like this. And I do believe there might be some folks on the line that are interested to reach out to you, Leanne, if they're interested to employ this at their hospital. And I see that you've entered your contact information here. So just want to say, it sounds like you were open to inquiries
Absolutely.
and chatting with people who are interested to do something like this and really understand the detail of some of the um the 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 detail behind what you all
Yeah,
are doing.
the details are heavy. Yeah. We did just go live with another market, another facility within our health system in our Mississippi market. And so slowly, our vision is to have all of our markets on the unit safety scorecard, where we can have not just a roll up at the inpatient, the hospital and the market level, but we can have it at the health system level. So we
Oh,
can
very cool.
develop it. And, I wish this was more of a fireside chat with, 300 of our closest friends to get all the details out there. But yeah, feel free to shoot me an email, and I will, we can set up time to chat or answer by email.
Leanne, we appreciate that. I do think we have time for one or two more. So I know some people were asking for a little more detail. So I would say if you're looking for more detail, reach out to Leanne, who could kind of walk you through a little bit more. But one question we got, Leanne, was how has the addition of the unit safety score on the quality board changed the big picture of shifting from Excel scorecards for other measures outside of safety, like HCAHPS, engagement, length of stay, etc.?
How has it changed? So we have opportunity around HCAHPS and patient experience. And in fact, I just had conversations this week with our health system decision analytics. What it has done is made people ask about what they see. When they see the screen and they see the data, they will, what is my takeaway? What am I looking at? Because with the unit safety score, they know their takeaway, and they know what they're looking at without even thinking about it. And so when you get, top box performance and percentile performance and this, that, and the other with, HCAHPS, people start to question, what am I looking at? Help me to understand how to, the question is operationalize this. I don't know that we have a lot of departments producing any Excel data coming into our patient units. A lot of it they're getting through Tableau. That may not come to their email and it may not get posted, but Tableau is part of our intranet. And so leaders have that link. They can go in and they can look at length of stay. They can look at it by DRG. They can, look at it by service line, hospitalist, or critical care. And so I guess, maybe we do a lot of electronic data feeds, if that helps to answer the question. Yeah. I will say that one change, so we do actually use this in our leader goals. And so many, probably most of our nursing leaders have the unit safety score as one of their three. We have 5 goals. Our leaders have 5 goals for the fiscal year. And as one of their 5, they have a unit safety score, and to achieve a 3 or higher on the unit safety score. So that was just introduced this year. So that has driven even more discussion about the unit safety score. And there was a question earlier about, what are the gaps and how do you close those? And so that conversation has happened even more because of the performance goals.
Awesome. Well, Leanne, you have answered most of the questions. We did have a few extras. So what we'll do, if we didn't have a chance to get to your questions, we'll send them over to Leanne and maybe get some summary responses and be able to send that out to this group. And then if you do have any questions about, that you want to talk to Leanne further, her email is on the screen. Leanne, thank you so much. Like, everyone is putting in this is a excellent presentation. Really appreciate you sharing. And I love that you put data into action to improve the culture of safety at your organization. And you can certainly see the impact and results. And if you are able to just go, oh, there we go. For our audience, thank you so much for all of your questions and for being so engaged. Just a reminder to get those CEs, you'll need to text the information on the screen within 24 hours in order to do so. And we do ask that you complete the evaluation form that will appear on your screen once the webinar ends. Leanne, we so appreciate your time. Audience, we so appreciate your time, and thank you for the wonderful webinar today. This will conclude our presentation.